Hello everyone, my name is Jenna Badger and I'm here with Cassandra Linney and Ashley Peck, and we're pharmacy students from Campbell University. Today we're going to be discussing venous thromboembolisms, or VTE, prophylaxis after surgery and hospitalization. Know the time and the place. For some background information, venous thromboembolisms account for more than 50,000 deaths annually in the United States. They are the third most common cause of vascular mortality worldwide, and 25% of venous thromboembolisms are caused by surgical procedures. Now that we've gone over some of the basics, we're going to go over venous thromboembolisms and what they are. A VTE is a blood clot, also known as a thrombus, that forms in the vein. VTEs encompass both deep vein thrombosis, or DVT, and pulmonary embolisms, or PEs. For DVTs, those are blood clots that form in the lower extremities and the inferior vena cava. And those thrombuses, once they're in the veins, they can travel through the bloodstream to other locations. And pulmonary embolisms are blood clots in the lungs and are also noted to be the leading cause of preventable death in hospitalized patients. Hip and knee surgeries, invasive neurological procedures, and major vascular procedures are some of the leading causes of venous thromboembolisms in surgical patients. Now that we've gone over this, we can talk about the Virchow's triad, which is used by modern medicine to risk stratify a patient's venous thromboembolism. So looking at the different circles, we have stasis, which is not being able to move and being sedentary, which is common for surgical patients as well as patients who are hospitalized. And this lack of movement leads to blood pooling in the veins, which can lead to a clot formation. We then have hypercoagulability, which is the overall increased risk of clotting in patients. And then we have vessel wall injury, where a thrombus can form at the site of injury at the vessel wall and can detach from the wall once the injury is healed, and that thrombus can travel through the bloodstream to other areas of the body. It's important to note that venous thromboembolisms are seen days to weeks after discharge from the hospital, and this is why the new recommendation is to have extended prophylaxis, which we'll get into later in this presentation. The overall goal of venous thromboembolism prophylaxis is to decrease morbidity and mortality in patients undergoing surgical procedures and to prevent fatal pulmonary embolisms in hospitalized patients.
Now let's dive into the treatments used for various surgical interventions. For hip fracture repair, your first-line agents would be using a DOAC or a direct oral anticoagulant. Your second-line agent would be to include low molecular weight heparin, like enoxaparin, or unfractionated heparin. For total hip and knee, your first-line agents are aspirin or DOAC. Your second-line agent is low molecular weight heparin, and your third-line agent is unfractionated heparin or warfarin. For major general surgery, cardiac or vascular surgery, and major gynecological surgeries, your first-line agents are low molecular weight heparin or unfractionated heparin. For urologic procedures, laparoscopic cholecystectomies, neurological procedures, or major trauma, mechanical prophylaxis is preferred. This includes the use of intermittent compression devices over compression stockings alone. If pharmacological prophylaxis is used based on the prolonged risk, low molecular weight heparin is preferred over the use of unfractionated heparin. For patients at high risk of bleeding, mechanical prophylaxis is recommended over no prophylaxis at all. Due to the increased risk of bleeding, pharmacological options are not preferred in these procedures. For those patients that Jenna previously described as having a high risk of VTE, combination therapy using pharmacological and mechanical prophylaxis is suggested. Now let's go into the guideline recommendations. Historically, we preferred the treatment of VTE prophylaxis using low molecular weight heparin and unfractionated heparin for 4 to 14 days. We're using the guidelines based on the American Society of Hematology, where extended prophylaxis is preferred over short-term prophylaxis. So this is used for 19 to 42 days versus previously used 4 to 14 days.
Now moving on into the treatments with oral medications or the DOACs, as Ashley mentioned. These include Coumadin, Eliquis, Xarelto, Pradaxa, and Savaysa. Savaysa, however, is not indicated for prophylaxis dosing, therefore it will not be listed on this table. For warfarin dosing, this is based solely on the INR and is dose adjusted accordingly. The goal for most people is between 2 to 3, unless the patient has a mechanical mitral valve, and then the goal is 2.5 to 3.5. The duration for warfarin is not listed specifically in the guidelines, but the 19 to 42 days, as Ashley mentioned, is preferred. Reversal agents for Coumadin include vitamin K, either oral supplementation or through injectable intramuscularly, or Kcentra, which is the prothrombin complex concentrate, or PCC. And for your reference, Kcentra dosing is provided at the bottom of this table based on the INR when it was obtained, if the reversal is needed for Coumadin. Apixaban or Eliquis is dosed 2.5 milligrams twice daily. The duration for a hip replacement is 35 days, and the duration for a knee replacement is 12 days. The reversal agents, if needed, would be Kcentra or Adaxa. Xarelto is dosed at 10 milligrams once daily, and this is taken without food or with food. It doesn't have to be. And the duration of treatment for a hip replacement is 35 days, and the knee replacement is for a total of 12 days. And it has the same reversal agents as Eliquis. Pradaxa or dabigatran should not be used in those with a creatinine clearance of less than 30. But if the creatinine clearance is above 30, the dose of 220 milligrams once daily for a hip replacement only for 20 to 35 days would be the duration for this agent. The reversal agents for Pradaxa include Kcentra and Praxbind. Now moving on into the injectable treatments. This includes heparin and enoxaparin, which Ashley has mentioned previously. Heparin is dosed at 5,000 units, sub-Q every 8 to 12 hours. The duration of treatment is 7 days after surgery or until fully ambulatory. The reversal agents include protamine. For this, in particular, it needs to be administered over 2 to 3 minutes to avoid hypotension and bradycardia. The max dose is 50 milligrams, regardless if you were reversing heparin or enoxaparin. 1 milligram of protamine will reverse 100 units of heparin. So enoxaparin dosing would be 40 milligrams subcutaneously every 24 hours, unless the renal function is below 30 mils per minute, and then the dose preferred would be 30 milligrams subcutaneous every 24 hours. Enoxaparin has a very special indication for prophylaxis for total knee, hip, or trauma, where that is dosed specifically at 30 milligrams subcutaneously every 12 hours. The duration of enoxaparin is 7 to 10 days following the surgery and up to 4 weeks. This can also be reversed with protamine, but depending on when the last dose of enoxaparin was given is how much you would reverse by. And if for some reason that low molecular weight heparin or unfractionated heparin cannot be used, fondaparinux may be implemented according to the physician's orders. It is important that whether you are treating or anticoagulating a patient using either oral medications or injectables, to always make sure that you're checking signs and symptoms of bleeding. Some symptoms and signs would be any unexplained bruising, no reason as to why bruising is occurring, or any pooling of blood anywhere on the body. If the patient is vomiting up blood, having blood in the stool or blood in the urine, that is another sign to seek help. And if the patient is unable to stop the blood coming out from a cut or a wound that has been bleeding nonstop for a while, that is also a reason to go and get help as well. Thank you for your time. I hope you have found the VTE, thromboembolism, prophylaxis, surgery, and hospitalization of patients, knowing the time and the place helpful, and I hope you have a great day.